So let us look at valvular heart diseases. These are diseases associated in various valves of the heart, like tricuspid valve, mitral valve, pulmonary valve, and the aortic valves in the heart, what they are affected and what problems they are associated with. So basically, it's going to focus on that on either acquired, either congenital type of diseases. So let us look at a normal functioning of a valve. So valves maintain flow, forward flow, and prevent reverse of flow. So they are in a way that the blood flow in one direction, but that is in a normal way. But in pathology, sometimes the blood can flow backward. So valves are open and closed in response to pressure and different ingredients between the cardiac chambers, either between the valvular, between the aortic, between the ventricle and the aortic part of it. So depending on these places, the blood valves either close and open in an organized manner. So let us look at abnormal valvular functions. And number one, we are going to focus on valvular stenosis. So this is where the thickening or the deepening of the stenosis become narrow. The blood, the heart valves become narrow. And the causes of valve stenosis is associated with what and what does it cause? So there is obstruction to valve flow during that phase of the cardiac cycle when the valve is normally open, meaning there is an obstruction, blood flowing through it instead of valve being open. And the hemodynamic hallmark pressure gradient flow in ventricle and atrium is affected. So the other is valvular regurgitations or insufficient or sometimes called incompetence, means that there is inadequate valve closure leading to backward flow of blood to the where it was originating from, either from most commonly from the ventricles. So a single valve can be both stenotic and regurgitant, but both situations cannot be severe. And combination of valve lesions can coexist. For example, in a single disease process, in different disease processes, in one valvular lesions may cause another, and certain combinations are particularly burden, for example, aortic stenosis and mitral regurgitations. So it can be a certain of burden, and this one is does not have a good prognosis to the patient. So let us look at mitral valvular competence. So the integrated functions of several anatomical elements which works in support of a mitral valve, as that one you have to be very conversant with mitral valves, is the competence is supported by posterior left atrium wall, the anterior and posterior valve leaflets and the condyle tendinae and the papilla muscles. Left ventricular wall where the papilla muscles is attached to. Those are the anatomical elements in competence of mitral valve. They have to be up to date, they have to be functioning well as goes of contractility and relaxation of and the blood flow in the mitral valve. So let us look at mitral valve diseases. What are the causes? What is the etiology of mitral valve diseases? So the mitral valve disease can be either a mitral stenosis, can have a mitral stenosis, and 99% is because of rheumatic heart disease. The other one is congenital, another one is prosthetic valvular stenosis or mitral annular calcification, and the other one is left atrial myxoma. The other one is acute mitral regurgitations, which is associated with infective endocarditis, ischemic heart disease, which is associated with the papillary muscle rupture, or is associated with mitral valve prolapse, which the most common mitral valve prolapse is condylar rupture. And the other one, which can cause acute mitral regurgitation, is chest trauma. Now, let us look at chronic mitral regurgitations. Chronic mitral regurgitation is associated with ischemic heart disease, And these ones causes papillary muscle dysfunctions, and this again ischemic heart disease causes inferior and posterior myocardial infarction. Myocardial infarction, then resulting to mitral valvular regurgitations. So the other one is mitral valve prolapse. Another one is infective endocarditis, rheumatic heart disease, prosthetic conditions, and mitral annular calcifications. And the other one is like things like cardiomyopathies, if cardiomyopathies can result to left ventricular dilatations or ischemic heart sclerotic syndrome. So let us look at mitral regurgitations pathophysiology. So mitral regurgitations pathophysiology is assisted with the mitral valve regurgitation results with the leakage of blood into the left atrium and during a systole piece of the heartbeat. And the primary abnormality is there is loss of forward systolic volume, volume into left atrium. So there is no volume of blood into the left atrium, and that is means that there is no feeling of what of systolic volume feeling of the blood in the atrium, so the blood flows back. The other one is compensatory mechanism issues associated with this one, like increased in systolic volume, and that is ejection fraction. Then there is another one of forward stroke volume, forward stroke volume plus regurgitant volume, stroke volume versus regurgitant volume. The other one is left ventricle or left atrium dilatations, or is another cause of compensatory mechanism which can be associated with mitral regurgitations. And the other one is left ventricular volume overload, left ventricular volume overload. So let us look at the chronic mitral regurgitations. Left ventricular volume overload is associated with left ventricle dilatations, eccentric hypertrophy, are the ones which causes left ventricle volume overload, increased left atrium pressure, pulmonary hypertension, dyspnea, all atrial arrhythmias, and low output state are a result of chronic mitral regurgitation. The pathophysiology of acute versus chronic mitral regurgitations is that in acute mitral regurgitations, there is a normal non-compliant left atrium, and there is increased left atrial pressure, and there is large volume V waves in the ECG, and there is acute pulmonary edema in acute mitral regurgitation because there is backward overload and backward. And that's what we call a preload. A preload is high, means the pulmonary circulation is affected, resulting to what is called a pulmonary edema. Patient start manifesting with dyspnea. Then we have chronic mitral regurgitations. Chronic mitral regurgitations. This one is there is a dilated compliant left atrium. Left atrium pressure normal or slightly increased, and fatigue, low output state, atrial arrhythmias like atrial fibrillations, and most patients fall between these two extremities. Most of the patients falls in these two extremities between mitral and regurgitations and acute phase and the chronic phase. So the physical findings in a patient who has a mitral regurgitation is that when you scrotate, the first heart sounds, the S1 piece is very soft or normal. P2 is increased, and there is systolic blowing murmur at the apex. That means there is a murmur throughout the systolic piece. The mitral valve pressure means systolic creak, and the ischemic in ischemic heart sclerotic disease, there is murmur increases with Valsalva. So in the acute mitral regurgitations, there's crescendo systolic murmur, there's crescendo systolic murmur, and the band heart rate is gallop and diastolic flow levels. Then we have hyperdynamic left ventricles. In these physical findings, we have the busy carotid upstroke and hyperdynamic left apical impulses. There is left atrial lift and left ventricle tap. So the mitral stenosis pathophysiology is that there is restriction of blood flow from left atrium to left ventricle during the systolic phase. So the normal mitral valve, average is 4 to 6 centimeters squared. Then in myocardial stenosis, mitral stenosis, it is 2 to 4 centimeters squared, and in severe mitral stenosis, it is less than 1 centimeters squared. So mitral valve pressure and gradient is also affected, and the mitral valve gradient is current to mitral valve flow per mitral valve mitral valve pressure. So the flow which is equal to cardiac output versus diastolic feeding period, which is cardiac output versus the diastolic period. Feeding period. So as a heart rate increases, then diastolic shortens and disproportionately, and the mitral valves gradient increases in this type of patients. And when you do a ECG, it resembles that there is a sharp T wave is increased in this type of patient. So, what is the relationship between mitral valve gradient and the flow from different valves areas? So, cross-arched areas indicate range of normal listing flow. So, the ventricle line represents the threshold for developing pulmonary edema, and the pressure gradient increases as the force increases to a small degree with a normal valve area of 6 to 4 centimeters. So to greater degree with a small valve areas and in severe stenosis, a significant gradient is present at rest. So in mitral stenosis, pathophysiology is that the mitral valve gradient is increased, leading to increases left atrial pressure. And also there is pulmonary hypertension, which can be either passive or reactive. And reactive, which is very common in secondary stenosis. In secondary stenosis, that's where we have reactive pulmonary hypertension. And pulmonary hypertension results towards the glucose of preload. So left ventricle pressure overload, left ventricle pressure overload because of left ventricle hypertrophy, or because of left ventricle failure, or also because of tricuspid regurgitations or systemic congestion. Congestic congestion, which is a manifestation of heart systemic heart failure. So there, that one is paradoxosis of mitral stenosis. There is disease of pulmonary arteries and left ventricle, and left ventricle unaffected. Unaffected, this one means it is protected. As left ventricle follows pulmonary symptoms and diminish, the pulmonary symptoms and diminish. So the clinical symptoms of mitral stenosis related to severity or mitral valve activity reductions. So symptoms and related to severity of mitral stenosis is like atrial fibrillation, systemic embolism. Symptoms due to pulmonary hypertension and left ventricle failure is like fatigue, low output state, peripheral edema, and hepatosplenomegaly. There is hoarseness and recurrent laryngeal and nerve passing. So the physical findings of mitral stenosis is on auscultation. You'll see that the first heart sound is variable intensifies and increased early progressive increase and decreases. And then the OS opening snap and variable intensifies the output fees. So the aortic versus OS intervals, there is variable invisible with the severity of my mitral stenosis and softness as mitral valve activities and diminish. So road pins to the historic rumbles at the apex and during and the division of mama correlates with severity of mitral stenosis and the systolic acculturation. So there is increase in preload and P2 and body habitats in the patient start having dimness because of cardiac cachexia. It's called cardiac cachexia, aesthetic and female. So low blood pressure, left atrial lift and left ventricle tap. So the mitral valve in echo findings, you see that the mitral stenosis is thickened, deformed with the mitral valve leaflets, and when you use the 2D Doppler, you see that mitral valve atrial activity is diminished and Doppler radiator sustain the left atrial ejection and left ventricle hypertrophy. So pulmonary hypertension, tricuspid and mitral valve and left valve functioning. So mitral regurgitations is a determinant of etiology, is the one which manifests is like leaflet, conda, mitral valve prolapse and myocardial infarctions. Doppler severity of mitral regurgitations is eject and left ventricular function. The treatment of mitral valve diseases is ideally surgery, but in mitral stenosis, medical treatment for class 1 and class 2 is that in control the heart rate, control you give the digoxin versus beta blockers, anticoagulants, antifibrils and drugs you give in a patient above than 40 years with the left atrium enlargement or mission to the myocardial with the mitral regurgitation. That's the time you give anti-fibrils and drugs. Then this one is prior to embolism events. Is a blood thinner to prevent embolism. So a surgical treatment in class 3 and 4 of mitral stenosis, we have grown mitral valvuloplasty and you can do commissural fusion and you can do preamble and calcified leaflets. If there is no mitral regurgitations of left atrium thrombus, do it again. Then in mitral valve surgery, you do open commissurotomy surgery, and also you can do mitral valve replacement. So in chronic mitral regurgitations, you do medical treatment for mild to moderate, and the mitral regurgitations with the vasodilators and vasodilators like centrally acting. And then you can give diuretics, anticoagulants. Then the surgical treatment idea is before the left systolic functioning and declines. It's the best time to do a surgical of chronic mitral valve. So in this one, you do mitral valve replacement, mitral valving, and also you do coronary artery bypass grafting. Then you do mitral valve repair associated with improved long-term in patients. Then left ventricular functions, for example, in mitral valve pressure, rupture, conda, and infective endocarditis, and popular muscle rupture. That is the time you do surgery in the left ventricular functions patients. So this is how the balloon mitral mesotomy is done in a patient who has mitral stenosis. So let us look at aortic valve disease. So the aortic valve disease, aortic can be stenotic, and the causes of aortic stenotic disease are regenerative calcifications because of age or congenital, which can be either unilateral or bilateral cuspids, rheumatic disease and prosthetic. Aortic artery insufficiency can be because of infective endocarditis, acute aortic dissection, and Marfan syndrome, chest trauma. Also can cause acute aortic dissection. So chronic aortic insufficiency is also a problem, and aortic leaflet diseases, which can be because of infective endocarditis, rheumatic heart disease, bicuspid aortic valve prolapse, and congenital ventricular defect. Prosthetic also is another cause of aortic leaflet disease. Aortic root diseases, aortic because of aortic either aneurysm, recession, Marfan syndrome, connective tissue disorder, syphilis, hypertension, and also annular aortic ectasia. So the pathophysiology of aortic stenosis is that the normal atrial valve activity is 2.5 to 3.5 centimeters, and severe cases of aortic stenosis is less than 1 centimeter. In critical cases, the aortic stenosis is 0.7 centimeters. And if it is less than 0.5 centimeters per meter squared, and the normal and the hemodynamic mark is the systolic pressure ingredient is okay, and then atrioventricular ingredient versus atrioventricular flow. That atrioventricular flow is equal to cardiac output versus systolic ejection pressure. Period. So the relationship between ventricular ingredient and the flow from different aortic valve areas is that, like in mitral stenosis, as flow increases, so does the ingredient increases, unlike the mitral stenosis, which be the other way around. So in resting, the flow are higher in a small atrioventricular area and shorter in systolic ejection pressure. So larger gradient is significant, more than 50 milligrams of mercury, and gradient can be present at least in asymptomatic individuals. Pathophysiology of aortic stenosis, left ventricular pressure output, chronic left ventricular pressure, and overload. It leads to concentric left ventricular heart failure, leading to stiffness of non-compliant left ventricle, resulting to increased left ventricular ejection pressure, and increased ventricular mass, resulting to increased mitral valve output. So, where tolerated for Dickens, people tolerate this condition for many years. Left ventricular force leading to congestive heart failure. So, it can also result to atrial fibrillations in it poorly tolerated, and loss of atrial kick, developing the heart rate, and acute pulmonary edema and hypertension. So let us look at aortic stenosis, which is natural history and clinical symptoms in this type of patient. So a patient, most of them are with aortic stenosis are asymptomatic for many years. They don't have anything except if they have mild problems because of exertion. Symptoms develop when valve is critically narrowed and left ventricle functions deteriorates. Bicuspid atrial valve is 5 to 6 centimeters decreased. And fifth and sixth decade and senior are seventh and eighth decades. That's the type, this type of that are happening either in Caspian age ventricular in the 50s, 60 years, the senior 70 and 80 years. So the classic symptoms of triad is that angina pectoris in 5 years, congenital heart failure in 1 to 2 years, and syncope in 2 to 3 years. And then this one can result to sudden death in the classical symptoms of angina of aortic stenosis. A patient developing angina pectoris 5 years, congenital heart, congestive heart failure 1 to 2 years, and syncope 2 to 3 years. Sudden death happens in the beings of aortic stenosis. So the natural history studies is that the patient ingredients 25 milligrams of mercury, 20% chances of intervention in 15 years. So patient with asymptomatic severe aortic stenosis require close follow-up. So starts follow-up and gradient progression is 6 to 10 milligrams per year. That is how it progresses. So the risk factors is somebody more than 70 years, patients with coronary artery disease, and patients with hyperlipidemia, and patients with chronic renal failure. So aortic stenosis findings is that is via the severity of aortic stenosis is that mild, moderate, and severe. So let us see in the carotid pass in severity of aortic stenosis is the carotid pass is normal in the mild cases, and the moderate it is rising, and the severe cases it is what it is pulse and thunders. So in left ventricular epical emphasis, the severity of aortic stenosis is mild is normal, and then every in moderate, and then every and static. So the auscultation, no findings. For the heart gallop, it is negative in mild cases, positive or negative in moderate, and this positive in the severe. So the systolic ejection creek is positive in mild, positive or negative in moderate, and negative in severe. So also the peak and also the CNE is also in early stages is in early systolic, in middle systolic, in moderate, and moderate systolic. So the third outcome is normal in mild cases when patients have aortic stenosis, and normal or single in moderate, and single paradoxical in what? In severe cases. So aortic insufficient, let us look at aortic insufficient pathophysiology. So this one, the primary abnormality is left ventricular volume output. So severity of left ventricular volume output is because of cells of the vagitant orifices in the diastolic pressure gradient between aortic output and left ventricle. So heart rate or duration of diastole and diastole. So compensatory mechanisms is left ventricular dilatation and ectasis, left ventricular heart rate, hypertrophy, and increased left ventricular diastolic compliance. So there is peripheral vasodilatation. So left ventricular volume versus pressure overload in this type of patient with the aortic stenosis is that what are the features? So the features in this type of patient is left ventricular volume is that the left ventricular pressure output is normal, and left ventricular volume output is dilated in mitral regurgitations and aortic insufficient. So the whole thickening in this type of patient is concerned in left ventricular heart failure and normal to slightly increased in left ventricular volume output. So left ventricle compliance is stiff and compliant in left ventricular pressure output, and increased compliance in left ventricular output. So this patient again, left ventricular diastolic pressure is increased in left ventricular output, and also normal to slightly increased in left ventricular volume output. So left ventricular systolic pressure increased in left ventricular pressure output, and left ventricular output normal to slightly increased. So this patient again, left ventricular ejection pressure is normal in patient who have left ventricular pressure output, and also it is increased in left ventricular pressure output. So let us look at aortic, acute and chronic aortic regurgitations versus. So the pathophysiology and clinical presentation. In acute aortic regurgitations, there is sudden aortic output volume incompetence, There is non-compliant left ventricle and acute pulmonary edema, and also there is a massive atrioventricular regurgitations. There is a chronic aortic regurgitations due to associated wrong asymmetric case, progressive left ventricular regurgitation, and difficult uh, dyspnea on exertion. There is orthopnea and there is paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea. There is a frequency of symptoms in this type of patients. So let us look at chronic aortic regurgitations, physical findings in this type of patient with chronic aortic regurgitations. So in this type of patient, there is a widening of pulse pressure. The pulse pressure is the pressure between systolic, the difference between the systolic and diastolic. So in this type of patient, there is wide pulse pressure, there is low diastolic pressure, there is dynamic left ventricle, which has and the massacred sign Corrigan's pass and against perstitution and Drusian's murmur. Then when we auscultate, there is diminished second heart sound and there's discrete diastolic blowing murmur at the left sternum border. So the Austin Flint murmur, which the historic pro-lambo at the apex and due to interference with the transmittal feeding by impregnated from aortic regurgitations. Ejection. So the differential diagnosis of these chronic aortic regurgitations is mitral stenosis increased due to increased intense with amiral nitrates. Let us look at aortic valve disease and diagnostic testing. So aortic stenosis, you do ECG, you do ANSA, and then you do left ventricular with the string, and also you can do left atrium enlargement and left atrial dystrophy. You see with the left atrial dysfunctions. You can do a chest X-ray frequently normal in this type of patient with aortic valve. Then you can do a 2D echo, which will show you aortic cuspid thickening, calcifying decrease in mobility, assessment of left ventricle heart failure and left ventricle systolic functions. The concomitant mitral regurgitations and aortic regurgitations. The Doppler assessment of aortic outflow volume gradient and implementary of atrioventricular area. So aortic regurgitations in this type of patient is that the echo will show left ventricular hypertrophy without strings. The chest X-ray will show chronic aortic insufficient. There's acute aortic insufficient resulting to pulmonary edema with normal sounds. So when you do a 2D echo, you assess aortic overall output form and roots. So you assess left ventricle functions, dilatations, left ventricles dimensions, which is more than 55 millimeters. So Doppler severity of regurgitations of severity of regurgitant jet. So the relationship between aortic ingredient and flow of different aortic valve areas is like the mitral stenosis. As flow increases, so does the gradient, unlike mitral stenosis. So resting flow are higher, small aortic ventricular area and shorter septal defect. So larger gradient significant more than 50 milligrams of mercury, and gradient can be present at rest in a symptomatic individual. So, balloon aortic valvoplasty indications for balloon aortic valvoplasty is in critical aortic stenosis, young patient with congenital aortic stenosis and predominant commissural fashion, bridge to eventual atrioventricular regurgitation, and moderate to severe heart failure, cardiogenic shock, or extreme high risk for atrioventricular regurgitations, urgent or emergency need for non-cardiac surgery. Patient with remittent respirant cardiac or non-cardiac patient who refuses to done surgery are the one who are done surgery, these type of procedures. So, aortic valvular surgery, which is called ROS procedure. There is auto-transplant of pulmonic valve to the aortic positions. There is the implantation of the coronary arteries and homographic valve in the pulmonary positions. Indications is young patients who are not using anticoagulant and require similar size of the aortic and pulmonary roots. And that is the head of valvular diseases. Thank you very much.